Good afternoon, and welcome to our discussion on asthma in children. My name is Christina Sperling, and I'll be helping to moderate this discussion today. Here at the Lung Association, we are committed to building a better breathing future for all. We do this by promoting healthy breathing, supporting those with lung disease, and finding future solutions. We are excited to have this discussion with you today, but if you do have any questions after this event, we do encourage you to contact one of our certified respiratory educators at the Lung Association. And you can see on the screen, there's the telephone number and our website that you can contact us at Monday to Friday between 8:30 a.m. and 4:30 p.m. Eastern Standard Time. Current statistics for asthma show that there are over 2 million people living with asthma in Ontario. 1 in 4 children are diagnosed with asthma, and it's the second leading cause of emergency room visits in children. Today, we are lucky to have this panel of experts with us to share their experiences and their expertise with us on asthma and to answer any questions that you have. Let me introduce our speakers today. This is Melissa Sullivan. Melissa was born and raised in Toronto, and she's lived here most of her life. She lives with her husband, Steve, and her 2 boys, Daniel, who is 7, and Brody, who just turned 4. They also have 3 pets, Buddy, Bailey, and Little G. Melissa has kindly offered her time today to share her experience with us, as both of her children have been diagnosed with asthma. Next to Melissa, we have Susan Balkovic. Susan is a registered respiratory therapist and certified asthma educator at the Hospital for Sick Children in Toronto. Susan works with families and children to help educate them on how to deal with their asthma appropriately. And last but not least, we have Dr. Theo Moraes, a pediatric respirologist and clinician scientist at the Hospital for Sick Children in Toronto as well. Theo has a clinic in the respiratory medicine division where he sees patients in the outpatient setting. We will begin our discussion today by addressing a few of the questions that have already come in from a lot of our viewers and hitting most of the broader topics that I think most people are interested in. After we address that discussion, we will then move into the questions that you will be feeding in live. So I do encourage you to send in your questions. We have some fantastic helpers behind the scenes here who will be taking those questions and feeding them to me through my iPad. So let's get started. Melissa, thank you again for being here today. Why don't you tell us a little bit about your experience with asthma with your 2 kids?
So, both of my children, I have a 7 and a 4-year-old, both first presented at about 9 months. And I think with Daniel, the oldest, I didn't know what I was seeing. Mm-hmm. And I didn't, because he's smiling, he's happy, and I just thought, oh, he looks like he's panting a bit, like a little dog. Maybe we should go to Emerge. And luckily, we live really close to sick kids. So we get in the car, we take him, not thinking it's such a bad thing. And then when we got there, it was this kind of really traumatic rush him to the back, get a bunch of doctors on him. And that was my first experience. Then Daniel was in and out of Emerge quite regularly. And that's how we met Sue. And so we got hooked up with the respiratory clinic. And then my second son, Brody, ended up also having asthma. But at that point, I recognized it because I was already better able to manage it through Daniel. And so we've just kind of been on this path. Yeah.
That's a bit scary to have that experience happen to you twice. Is there any tips or thoughts that you want to share with people who might be new to asthma and not really know what they're dealing with? So when you first said that Daniel had those, he was panting, mm-hmm. Were there any other signs and symptoms that you were noticing that were alerting you something was wrong?
No, because no one in my family was asthmatic. I hadn't had any experience with it, and they didn't even call it asthma at first. I think they called it
wheezing illness, or
no, they called it because I don't think they want to. It's not asthma, right? When they're so young, it's I can't remember what it's called, but because he was happy and he was playing and he was smiling and he didn't seem sick. I just thought he had a cold. Mm-hmm. so after that, I realized a cold's not just a cold. And so that kind of has become our new reality, is that a cold isn't just a cold. A cold is actually quite dangerous for our kids, which is hard when you're sending them off to daycare and they come home with a cold every 2 weeks. And so a lot of that is just becoming more experienced, and you kind of have to ride the ups and downs. And when it's down, it's down. But it got better. It really did get better, and I think seeing my older son get better, I had a lot of hope that my younger son, it was going to be getting better too.
That's great. That's great. Dr. Moraes, from your experience being a pediatrician and dealing with these families as they come through the clinics, what kind of things do you say to your patients when they come through, or what are some of the key things that you want to make sure that they hear?
Sure. So you can call me Theo, by the way, Christina, because it's hard to say Moraes all the time. So there's a couple of things that I would say. First off is, while there are ups and downs, certainly with asthma or an asthma label, I think the main thing is don't panic, because the vast majority of children who are labeled with a diagnosis of asthma do very well, and with minimal amounts of medication to keep them under good control. So that's something you should remember. Don't freak out. The second thing, that if I was going to say something to everybody out there in the world, would be after you interact with your healthcare provider, make sure you leave with an asthma action plan, because I think that provides you with some written evidence of what you should do. And also, if you have to interact with someone else in the emergency room or somewhere else, you can bring that piece of paper and show people what your plan is actually entailing. So those would be the two things. Don't panic. Get an asthma action plan.
Great. And Sue, from your experience, you're an educator, you work directly with the families. What are some of the things that are key for you to address with them right off the bat when they're newly diagnosed with asthma?
Yeah, so when they're newly, when they're newly diagnosed, I think that one of the most important things to know is to understand the medications, how to use them, when to take them, and the appropriate way of using the delivery device. I think those are sort of the key things. Also the environmental control, because asthma and the environment are very much related, and those are sort of the key things that I like to talk about.
Can you expand a little bit more on the environmental controls? Like, what do you mean by that?
Sure. So asthma is very correlated with allergies as well, and the environment. And there are, if we can go into the triggers now, if that's okay.
Yeah, of course.
In terms of there are things that can trigger someone, and I think it's very important for families to understand and have the knowledge in the background, so that they can be a little bit like private investigators, I like to call it, so that when they do understand what different triggers are, that they can see how their child reacts with that. And so going maybe into the home, there are various triggers that we have in the home. Things like dust mites are one, which is very different from dust itself. So there's the sort of renovation dust, which is an irritant, but then there's also dust mite, which likes to live in our beds. There's also, there's molds within the home, and there's also pets. Sometimes our pets can be our triggers. And I'm just trying to think, also things in the home might be such as strong smells. So either from, especially from children with, smelly markers or incense, or even from cooking as well. And those could all be triggers, but it's a matter of everyone has very unique triggers, and it's important to understand that. And as you become a bit of a private investigator, you see how your child reacts with any of these triggers.
Okay, that makes sense. So, Melissa, you said that you had three pets in your home. Have you noticed the boys are fine with them? And
Yeah, so when we got our initial diagnosis, it was a really hard thing, because we had two of the pets before the children were born, and Daniel loved the pet, right? And so one of the considerations is, are we going to have to get rid of our pets? And I gave it serious thought, and I was willing to. I absolutely was willing to, if that's what it had to be for the health of my children. But I also didn't want to just be reactive and just get rid of the pets. if I didn't have to, because there's a love bond there. And so, we had to do some research, and part of our thing was they didn't know really what was triggering. Brody is the worst case, like he's really bad. And so we did some allergy skin testing, and he didn't have a positive reaction to cats or dogs. So that kind of settled me down a little, in that we were okay with keeping our pets. At the same time, the pets don't go up to their bedrooms. And we have all kinds of other things, like we have the mattress protectors. I vacuum regularly. There's all kinds of little things you can do to try and control the environment, like what Sue was saying. At the same time, we didn't know what some of our triggers were. We found that whenever we took Brody to go visit his grandmother when he had a cold, we often ended up in Emerge. So we felt there was something in Grandma's house, the carpets or something. And so we learned that when we suspect if he has a cold, because it was always related with viral cold as well, if we even thought he had a cold, there would be no going to Grandma's house, right?
So you really did act like a private investigator. You were trying to check out what was
it's
happening.
frustrating because you don't always get your answers, but you can come up with a plan where you put certain things into play when you're dealing with an exacerbation.
No, that makes sense. That makes sense. Sue, just to go back to what you talked about a little bit in terms of the medications and just proper technique, is there anything that you see people often do that maybe we can highlight right now so that it can be, people can really pay attention to that in terms of taking their medications?
Sure. I think most children, especially when they're younger, they will get a puffer in the form of a pump. We call it a meter dose inhaler, so an MDI. And the most important thing is that you use that with a spacer. So it's a valved holding chamber, and what that does is it allows the medication to be suspended within the chamber in order for the child to take it appropriately. We do not really recommend, especially children, even if you're 50 years old, to take that without a chamber, because it allows for better deposition in the airways, and therefore you get better relief from the medication, you don't waste the medication, and you get less side effects that way as well. So I think that's probably the key take home with that.
That leads me into my next question. That's great. Theo, some of the medications, a lot of people are nervous about taking medications on an ongoing basis. Can you talk a little bit about that, the importance of taking them regularly, as well as any of the side effects that you might be seeing?
Yeah, I think this is very common. I mean, most parents don't want their children to take medicines. And if you look stuff up with Dr. Google, you'll find a ton of side effects that can be reported with different asthma medications. So a couple of things, I guess. One is the main way to really reduce the amount of medicine you're using is to take it properly. Because I think really it's the asthma attacks that are associated with higher concentrations or higher doses of steroids or higher amounts of rescue, bronchodilators, sometimes antibiotics as well. People just will give it because they're not sure what's going on. And so to minimize all that, I think using your medicine regularly is a key point. The second thing that I would probably emphasize is the fact that doing that can be tricky because with any prevention, if you're doing it properly, nothing happens. And so it's very hard to do that, right? It's not like you take it and you suddenly feel better. You're taking it and nothing happens. And so I acknowledge, and I think a lot of parents feel like, why am I doing this? Nothing is happening. Do I really need to do this? And so most physicians will try and use the least amount of medication possible to keep kids under good control. But in terms of minimizing side effects, I think the key is to make sure you're taking your prevention properly. In terms of specific side effects, so the rescue puffer, like Ventolin or the blue puffer, sometimes if you take high enough doses, you'll start to feel a bit agitated or a bit kind of keyed up because it is a relative of adrenaline. But if you need that medicine, taking it as you need it is not going to hurt you. So if you're on your way to emerge, don't worry about it. Take as much as you need to until you get there. And you'll see that in the emergency room, we sometimes give kids continuous Ventolin. I mean, obviously they're in a monitored situation, but if you need it to get relief, take it. In terms of inhaled steroids or oral steroids, At the doses that the majority of kids are taking, I'm not really worried about side effects. Some kids will get issues with thrush or other things if they're not using the spacer properly. But at low doses, generally kids, it's well tolerated. Once you get at higher doses, you can see effects long-term in terms of, some studies have reported slightly shorter adult height, like maybe by 1 centimeter or so. People will be worried about bone density at higher doses, or adrenal glands, because the adrenal glands actually make your own steroid. And so if you're taking steroid from outside, your adrenal glands say, hey, I don't need to work. So you can see. But again, those are side effects you'll read about. And if you're taking a low or moderate dose of inhaled steroid, that will be fine. Yeah.
Thank you. One of the questions we did get ahead of time was about alternative therapies. So is there any breathing exercises people can do to help instead of taking medications, or?
Yeah, and I think this is something that's very popular because sometimes asthma, like any chronic disease, can be very frustrating. And so you're looking for anything else that may help. There isn't a lot of data or any data to support that breathing exercises on their own are an effective alternative for anti-inflammatory medicines like controllers or rescue medicines. So I wouldn't recommend that. If you're doing breathing exercises as part of your regular medication, I mean, it's not going to hurt you. So I don't think there's any harm. Yeah.
Perhaps maybe with that feeling of anxiety when a patient or a person's having an attack or having trouble breathing. I'm not sure if that's what's helping, maybe just to calm things down.
Yeah, so anytime you feel breathless, you're going to feel anxious. And I think in the olden days, people often would say, oh, asthma, it's just in your head because you're so anxious and freaked out. But you know what? If you're having a hard time breathing, you're going to be freaked out. And certainly, sometimes anxiety can give you a feeling of breathlessness. And so it can be difficult in some people to differentiate what's an asthma attack because of one of Sue or Melissa's triggers, like smoke or whatever, versus they're just feeling anxious. And so for some people, taking a second to take a few deep breaths can relieve the anxiety and make you feel better. But if you're having a true asthma attack, slow breathing or deep breathing won't change that. You need to take your rescue puffers or go to the emerge or do whatever is on your action plan.
I see you nodding, Melissa. So do you have anything to add to that, or based on your experience with your kids?
Yes, well, just to piggyback off of that. So Daniel is now 7, but, one of our fears sending him off to school, to kindergarten, is that you can't, he's sick so often that you can't keep him home all the time. There's a point where he's well enough to go to school, but he's still not 100%. And I think one of the things that built my confidence as a mother was his own sense of body awareness. He also has anxiety, and he knows very well the difference between feeling anxious and when his lungs are tight. And in addition to that, there's often other symptoms that go with the asthma attack that don't come with him just feeling anxious. And so, the little coughs, there's just little signs that kind of come together, and you'll know what you're dealing with. And that might not come right away, but the more experienced you get with it, you actually start to feel more comfortable and you calm down with it. But his breathing, I think too, breathing exercises and breathing properly work really well for Daniel because that helps in the administration of his medication. He knows, he calms down, he takes in deep breaths, and when he takes in deep breaths with his puffer, I feel like he's getting a nice full dose of his medicine. And so the breathing helps both calming him down, but also helps with managing his medicine too. So
that makes perfect sense. Yes, absolutely. Talking about breathing more and deep breathing, exercise. So kids are kids and they want to run around and stuff. So a lot of the questions that we did get ahead of time as well was around exercise. Are children limited by asthma, and are they able to be active out playing soccer, playing with other children? Sue, I'll ask you to comment on that first if you don't mind.
Sure, yeah. I think it is very, very important to realize that just because someone has asthma or a child has asthma, that you should not be limited by your physical activity as a result. Physical activity is extremely important for your lung health and for your overall health. What we need to do is we need to ensure that the child's on the right medications and also the right environmental control and avoidance strategies in order to exercise and be at your optimal for physical activity. A lot of people will limit their children as a result of their asthma diagnosis, but I really feel that it's very important to understand that once the underlying asthma is under good control, a lot of the exercise symptoms will actually go away. And in the reverse, when you're actually in good control of your asthma, especially for children, when exercise symptoms are usually the first ones that will appear when you start to get out of control, and then you can use your action plan accordingly.
I'm glad you brought up the action plan again, actually. Yeah. Can we tell viewers a little bit more about the action plan and why it's so helpful?
Sure. So in terms of the action plan, it allows you to, the way I like to explain it to families is that it's a step-by-step process. And it's sort of like the green, think of it like a stoplight. So green light's a go. Good control essentially means that you don't have symptoms more than 3 times in a week. These are all based on sort of consensus guidelines as well, that you're not waking up in the middle of the night at least 1 time during the week with any kind of asthma symptoms or needing your rescue or reliever puffer. You come when you are above and beyond that, again, normal physical activity, not missing school, those are sort of a given. That's sort of when you're in the green zone. Anything above and beyond that, then you're sort of in the yellow zone. And I think this is sort of a key because what we want to do is we want to prevent from getting into the red zone. So it's important that there are things there that you can do. And one of them is how you can step up your medications, what you can do at that time, but also it's an opportunity for you to be able to go and see your medical provider and get assessed at that time so that we're not ending up in the red zone.
Great, thank you so much for that. Just to get back to you, Melissa, getting diagnosed with a chronic disease such as asthma can be, a little bit difficult or challenging for a family at times. Can you comment a little bit on how your family, dealt with that emotionally, like that drain a little bit on the family?
I don't think it was this kind of like, oh, he has asthma, what's the impact on his life going forward? I think because when you're in the moment when something's bad, that you're just dealing with the moment. And so for Daniel, we ended up in the hospital a lot. We were in Merge a lot, but then when he was healthy, and so we were good. And I did notice the more we got on point with taking our medicine and the more that we had connected with Sue and Sick Kids, having a good treatment plan that we stuck to, the good moments got better, right? And that the first sign of a cold where we might end up in the hospital, if we go right to our asthma treatment plan, we don't have to go to the hospital because we've managed it at home. And I think it even got to the point where, we were dealing with some asthma attacks or exacerbations from Brody, the littler one who's more sick, actually. What would have put us in the emerge before, we were handling at home and we were feeling good about it. I mean, we had our threshold where we had already decided we're going to the hospital at X point, but that was part of our treatment plan. For Brody being so sick, I think my husband got hit harder than I did because he was so much worse than Daniel and we didn't have any answers, that he was kind of scared a lot. But even that, I kind of banked on hopefully he'll follow the same path as Daniel, and as he gets older and as his lungs get stronger, he'll get better. And he is. He's getting much better. He's still asthmatic, but we're not in the hospital as much. We don't have as many exacerbations. So, the stress is more dealing with the moment, the all-nighters, getting sick at midnight and there's nobody to call for help, spending your whole night in emerge and then getting home at 3 or 4 in the morning and then going to work the next day. That was more kind of our stressors.
And that makes sense. Yeah, that absolutely makes sense. It's not easy. Absolutely. Just to go back, some of the questions I am getting on, they're starting to come in, is just about if we could go back to the beginning again and just talk a little bit about asthma and it being a chronic disease. What does that mean? What are the effects on the body? Just to kind of get that foundation. Theo, yes,
Yeah.
I'll ask you to, sorry, yes, I'll ask Theo to answer
Okay.
that, please.
So, asthma, it's a funny thing because to me, when I'm teaching people now in, trainees or medical students, I always say that asthma is an incomplete sentence because when you say someone has asthma, I'm not entirely sure what you mean by that if you're a doctor talking to me, because asthma it's a clinical diagnosis. It's based on symptoms. It's based on the fact that you are fine most of the time, but then you get episodes where you have an asthma attack and you have a hard time breathing. And you cough, you have wheezing, you have chest tightness, and it kind of comes and goes. But there are different things that can give you that pattern, and things may change over time. So for a lot of people, asthma is a disease that is there for your lifetime. But for many people, that kind of pattern of symptoms is something that isn't there for their whole life. It may be there when they're little and go away. It may be there when they're 30 years old and working in a certain environment, or it may show up when they're older. And so when we talk about asthma being a chronic disease, I think it's implying a certain subset of this, where it is a pattern where children's lungs are just overly sensitive. They just kind of overreact to things that other people are like, oh, no problem. And so that's the part of the chronic disease, I guess.
Okay, that's great. Thank you. You talked a little bit about clinically diagnosing it. There's something called spirometry that can be used to also diagnose asthma. Can you talk a little bit about that?
Yeah, and I think it's important to know what spirometry is. Spirometry implies that, or is, an objective measure of lung function. So the vast majority of kids who are school age, so 6 and up, should be able to do spirometry. And it certainly helps us as doctors get a sense of what's going on in the lungs because, we can ask you questions, but a lot of that is subjective. How do you feel? Do you feel tight? And so on. But if we get objective measures, we can actually see what are the lungs doing. So in spirometry, we ask people to take a deep breath in and blow it as hard as they can, and we measure the air that comes out. And generally, we measure how much comes out in 1 second. We call that the forced expired volume in 1 second, or FEV1. It's a fancy way of saying how much air comes out in 1 second, basically. In asthma, when you're having an asthma attack, your airways get narrow, and so less air will come out in 1 second. I tell people it's like a door. If you have a small door and you try and run out in 1 second, everybody has to line up. It takes forever. But if you have a garage door, everybody runs out at the same time. It takes no time. And same kind of thing with spirometry. When you're having an asthma attack, your airways get narrow, your FEV1 is reduced. We give you some Ventolin to open up your airways, and then we can see an improvement. And so that certainly supports a diagnosis of asthma. It doesn't tell you for sure that this is somebody with sensitive lungs, but it supports it. Yeah. So I would recommend that anybody who's school age and up should be having spirometry. Yeah.
Okay, great. And then what about the kids who are under 6 years old? So how do you
Yeah.
how do you diagnose them then?
And I think, Melissa, you were alluding to this too. When you have smaller children, it can be tough for a couple of reasons. One is we lack good standardized objective measures. And the second thing is kids will just wheeze and cough for anything. Like as a pediatrician, it's sometimes annoying. You're like, what are you doing? Why are you coughing with this? But it's true. And so about 40% of children will have a wheezing episode with a virus. Does that mean they all have asthma? Does that mean they all need steroids? It can be tricky to tell. And so for a lot of doctors, they're reluctant to label somebody with a diagnosis of asthma when they're little, because for a lot of parents and everybody else, asthma means a chronic lifelong disease. But the reality is a lot of these children who are wheezing and having symptoms when they're small will outgrow things. Their airways will get bigger, and then they won't get the same kind of symptoms with colds.
That's great. Actually, the question that just came in was what percentage of people actually outgrow asthma? Do you have any idea what that might be?
Yeah, so that's where it's tricky because, if you're labeling everybody who wheezes in infancy with asthma, then a good proportion of people will outgrow asthma. But because, maybe they didn't really have sensitive lungs to begin with. They just had small airways. They're just born with smaller airways that grew with time. But when you look at children who are older, school-age kids who have real allergic-y asthma that responds to steroids, I think fewer of those kids will outgrow that pattern. It can wax and wane, and certainly there are, I mean, we always hear stories about people who, you know, they live in a certain environment, they're exposed to something that's constantly creating a bit of inflammation, like if they're allergic to cats and they happen to have a girlfriend who has a cat, and then they leave the girlfriend, leave the cat, and suddenly they don't have asthma anymore. And it, you know, so you will see patterns like that. But I think if you're talking about school-age children, most people will continue to have symptoms.
To Sue, one of the questions that has come in is about the chamber that you talked about to deliver the medication, and someone's asking if if all different chambers are equal. So there's different products out there on the market. There are. Yeah. And they're wondering if does it matter which one they purchase? Is one better than another?
Well, I'm not here to endorse anything, but I do like the chambers in which there's at least some sort of valve that you can see, that you can actually see moving. So, okay. I mean, there's two different things here. You're looking at ones with a mask and then ones with a mouthpiece. So the ones with a mask, what you would do is you're actually looking at the child breathing a number of breaths in order to empty the chamber. And the important things with a valved holding chamber is that it will only deliver the medicine on inspiration when you open up this valve. So I like the chambers where you actually have a valve that you can actually see, moving, so that you can feel confident as a parent that they've actually received it. You also feel confident that they have a good seal, and especially children when they're younger, they like to move, and you're not really 100% sure. So I do like those chambers. And the same with, you know, when we're transitioning to a mouthpiece chamber, the delivery method is a little bit different. And so there are a whole bunch of things that we look at. We got to make sure that they're not breathing through their nose, that they have a nice seal around the lips. So I do like those chambers because it gives you a little bit of a feedback mechanism. So that's would be my recommendation.
Okay, I like that. That's great. Thank you. Can we talk a little bit about air quality? One of the questions that's come through is about relative humidity and how that affects asthma. Does it make it worse? Is it better? I don't know who wants to take that one on.
I can say something.
I want to talk about air quality. I wanted to talk with respect to relative humidity in the home. So
okay.
Go ahead. Why don't you state?
So one of the things with there's a correlation between triggers in the home, such as dust mite and mold, and the relative humidity within your home. So dust mites are microscopic, and they love to proliferate in humid environments. And mold likes to proliferate in humid environments as well. So we recommend keeping the home at a relative humidity of about 30 to 50%. So this time of year, not very difficult. It's actually too dry a lot of times. In the summer though, especially in around the Great Lakes area, it can be quite high. So even being in air conditioning itself can just bring down the humidity in a home. So that's what, I mean, in terms of that's what we recommend from that perspective, from the triggers. But in terms of, if you want to talk about air quality.
Sure. So I think air quality and weather in general can certainly be a trigger for people. And so it can be extremes of anything. Like, so very cold weather can be very drying for the airways. Very, very hot weather that's very humid can also cause some labored breathing. Some of that can be associated with pollen counts. Some of it can be associated with particulate matter or smog that can all irritate the airways. And so in some ways it is individual, because some people are a little more sensitive to certain things in the environment, whether it's pollen or smog. But at certain levels, everybody will eventually have a hard time breathing. Yeah.
All right, thank you. One of the questions that has come through is about school. So sending your child to school, were you nervous at all about that? Or when you sent Daniel to school for the first time, how did you handle that whole situation? And I mean, you're a teacher as well, so you're going to give us a little bit on both sides. So do you want to talk about that?
Sure. So again, I do think part of your confidence in being willing to let them go is that at 5, he was really good at taking his medicine. Like even, they both learned to count using their chambers. It's kind of sad, but because, right? in Armenian as well. So like we learn both languages by counting on our chambers. But so sending him off to school, I think you really have to advocate for your child. And the school is also bound. They have an asthma treatment protocol. It's Ryan's Law. And so every classroom in my school, has a poster up out by our door that we're supposed to post, and it tells you the steps of how to deal with an asthma attack. We talk about it as an opening discussion at the beginning of the school year. But at the same time, I think that can kind of go in one year out the other when they're dealing with so many other things, and it kind of becomes peripheral. So as a parent, not the teacher, I went in and I printed off the forms. We filled out the asthma treatment plan. I typed up a personal document saying, this is how his asthma presents. This is what he will look like. And when he started at 5, even though he has a really good body awareness now, he didn't always. So he could run around this little like puffy cough. And because that was his normal, he wouldn't even register that he'd need his puffer. So I had to get his teachers on board to say, when you hear him coughing like that, could you please ask him about his puffer? And sometimes you would also get some resistance. I think there was some fear that if he had his puffer available to him, other young 5-year-olds might get into his bag, they might find the Ventolin, they might overdose. And so you really have to address some of those, the stigma or the fears with that he's not going to overdose. If he ever asks for his puffer, you give him his puffer. And that you also have an obligation to keep an eye on him because he might not be aware. But they've been really good with that. But you have to be outspoken. Our daycare, the youngest one was in daycare, and she felt too overwhelmed with Brody's asthma, so she actually asked us to leave, which was hard. But at the same time, that's what I would have wanted. Because if you fear that you can't care for my child, then I don't want that either, right?
That totally makes sense.
Yeah.
You mentioned the form. Where do you get this form that you could give to the teacher to really outline?
So I sent you a copy. It's on, you can Google it. If you Google TDSB or whatever it's a TDSB form, but other school boards would have their own. But it's called the Asthma Treatment Protocol. And Ryan's Law, so if you just Google those keywords, it will pop up, and it's a document. When children are starting school, the main office should have those forms, and they should also be sending home to you. If you don't go in with them, they should have them on file and should be asking you to fill out their plan. Yeah. And then his children with these health issues will have their face and their kept private but posted in the staff room or the office so that they're kind of like a high alert, and that the other teachers should be made aware of his status and how to keep an eye on him.
Good. I like that you said that parents really need to advocate, because it's true. Teachers have so many things to learn about, but this is really something that they need to pay attention to. So it's nice to hear that you're advocating on your child's behalf.
Can I just add?
Absolutely.
I think it's also important that you share the action, that you share the action plan with the schools. I mean, I've dealt with a lot of schools. I've had to go in and do some education with the staff and in some of our severe cases, because I think there's just sort of a misperception that it's mild, whereas our cases that we deal with are quite severe. It's important to share that, but also to have that back and forth communication with respect to how many times have they actually needed their rescue and reliever medication, because that should be a good feedback mechanism to the family members and understanding when you're starting to get out of control. And again, a lot of them have standardized forms, but that information can be transcribed onto that. So I think that feedback mechanism is extremely important.
No, that's absolutely right. At the Lung Association, we also have some information on our website about keeping your homes friendly for asthma, as well as how to support sending your children to school, some information, some checklists on what you should be thinking about. So there's lots of information out there for parents to be able to deal with that. So thank you for addressing that. Someone's asking, is Ryan's Law specific to Ontario? I believe it is. This year, schools were mandated to put policies in place, and you can help support me on this, but policies in place to be able to support certain prevalent medical conditions, one of which is asthma, so that teachers are obligated to learn how to deal with asthma attacks, as well as support children with their medications. And there needs to be policies in place for the school boards. So,
And I think a big part of it too is that in the past, schools didn't like young children having access to their medication, so it would be kind of taken away from them and put somewhere in the hands of the adults. Where here, he is allowed to have access to his medication. He keeps his puffer in his bag at all times. And if he feels that he needs his puffer, as part of our asthma treatment plan, I said, if he ever asks for his puffer, he gets his puffer because he knows.
no, that's great. That's great. One of the questions, just to go back to the aero chamber, someone's asking about when do you move from a mouthpiece from a mask to a mouthpiece? Like what age range would that happen at?
That's a very good question. So the main thing is the ability to follow instruction. I think that is because the way, just really quickly, how you do it with the mouthpiece is you have to exhale completely, be able to pump, have a nice seal, be able to breathe through your mouth, not through your nose, take a big breath in, you have to be able to hold it for 10 seconds. So having that ability, one of the things that we have the luxury of doing is spirometry at Sick Kids. So once we see that a child is able to do spirometry because you have to take a big breath in and blow and be able to follow instruction, we sort of look at that as a time to transition. So we have 4-year-olds that are able to transition and we have 8-year-olds that are not. So it's a matter of being able to follow the instruction. And again, most importantly, to be able to have a good seal with the mouth and not breathe through the nose.
So it's not about an age, it's about the
No,
coordination.
it's really more about about their ability to follow the instruction and to do all those steps. That's why I think it's actually a very good idea to have a medical professional, an educator, or someone to actually observe that. We do a lot of return demonstration. Even when people come for follow-up visits and they do a check, we do a check, we always ask for a return demonstration, and there's always some little piece that we can always improve upon. So I think it's important that that's addressed. There's videos. I know the Lung Association has some great videos. I think it's really important that that's sort of addressed and followed.
Great, thank you.
If I could just say something, I'm not sure if there's a number, but a lot of the lack of control that we see in kids, it has to do with the medicine not actually getting into the lungs. And so people think they're taking the medicine appropriately, but it's not actually getting in. And so when Sue or other asthma educators refine things, you often see asthma control improve because now the medicine is actually getting in there. And a big part of that is using the aero chamber properly.
Great. Just going back to spirometry, one of the questions is if you have the asthma symptoms, but your spirometry does not suggest that you have asthma based on the findings. Is there other testing that can be done after the bronchial challenge has been noted here? Or do you go straight to steroids? Or what's the next steps if you're kind of conflicting there?
Yeah, so basic spirometry, if you're well, will look normal. And if you give somebody Ventolin, they're not going to change because they're already at 100% of what their normal is. So there is a challenge test that you can do. There's a methacholine challenge, there's allergen challenges and exercise challenges, but we use a methacholine challenge more standardly because if you have a negative methacholine challenge, you are very unlikely to have asthma. So that's how we use a methacholine challenge. A positive methacholine challenge, so you react to methacholine, doesn't tell you 100% you have asthma, but it's, again, consistent with the diagnosis.
Okay, thank you. Thank you for that clarification. One of the questions that's just come in is about brittle asthma, and that's in quotations. This viewer has a niece that's 3.5 years old and has been admitted 6 times in the last 8 months with asthma. So does anyone, I don't know, Theo or Sue, if you want to address?
Yeah, so I think it sounds like she's quite sick. Admitted 6 times in 8 months. So we certainly see children like that at Sick Kids, and it probably my advice would be to to try and see somebody with expertise in that area to make sure she's being well managed, and first of all confirm that this is really asthma and not something else. Yeah.
So specialist, should she see a specialist?
I think so. Somebody, well, I mean, I don't want to get into a debate about pediatricians versus respirologists and get yelled at and stuff, but I think somebody with expertise would be great. That's what I would suggest. But I mean, a 3-year-old getting admitted 6 times sounds like maybe she should see a specialist. Yeah.
Okay, great. Another viewer has, my 5-year-old son has us, his parents, everyone around him helping him take his puffers every morning. Should we be encouraging independent use?
That is a really great question, because we see some 2-year-olds that are able to take their puff it and do it, and you can probably relate to this, Melissa. This is always a big challenge because compliance and adherence to medications is extremely important, and like Dr. Marius had said, is the technique and the delivery is extremely important in order to get optimal asthma under good control. I think it's definitely good to encourage the independence, but I think it's always something that needs to be followed up on. A lot of times we see in clinic, have you taken your medication? And the parents and the children are looking at each other. Did you take it? I don't know. Did you? And so we do see this a lot. That's why the follow-up visits are extremely important, and ensuring that you do have regular follow-up. I definitely think encouraging independence is important, but I think it should be a step-by-step process, and then sort of check-ins every once in a while.
Did you have something to add?
Well, we included it. It's part of our normal routine. So we made a little chore chart for Daniel of his responsibilities, and get dressed, put away your toys, brush your teeth, take your puffer, and we had a little cartoon puffer on the side. And of course, just like any other skill, you observe them brushing their teeth until you're confident that they're getting it right, and then you can send them off to go brush their teeth, which I think will build your confidence in being able to send them out into the world and not worry about them so much when you know they're good. But yeah, it's like any other life skill that they have to.
Yeah, that makes sense. That totally makes sense. One of the questions here is about Theo or Sue, perhaps you guys can address this one. Parents who are not willing to give the steroids on a daily basis, I guess they don't like the idea of giving the medications, which we addressed at the beginning, but some parents stop giving the inhalers if there's no symptoms really, so the child's fine. How do you handle that with parents that come in, I guess, at the next episode?
Yeah, and again, it goes towards using a medicine when you don't see any benefit, because it is really a prevention, and if you use it properly, nothing will happen. And so it is hard for people to commit to doing that. I think you have to take a step back then and look at the pattern of symptoms over a few months. So if the kid has been off medication for months and nothing's happened, then fine. I mean, that's great. The least amount of medicine you need is nothing. So perfect. But if every time you come off your controller, you're having attacks, you're in and out of emerge, or you're needing to use your blue puffer, and on that asthma action plan, you're kind of out of control, then that speaks to the fact that, we need to do something different. And if your diagnosis truly is asthma, that's something different, is a low dose of inhaled steroid as a starting point to try and get that under control. I think my experience is that most parents, their fears, if you can kind of talk to them, you can get over it, because we're not here to injure kids. We're not like giving them steroids because we're trying to hurt children, or we're trying to make money because we own the drug companies or something. We really are trying to help kids have a normal life, go to school, sleep through the night, not go to emerge. That's really what we're hoping for. So when we're prescribing these medications, we are weighing the pros and cons, and based on our experience and our judgment and all the evidence out there, it would seem like the pros far outweigh the cons. And if we can't communicate that with the parents, it just means we need to sit down and talk more, I think, and communicate better.
I think one of the things that people have to realize is that the controller, the inhaled controller takes at least of about a good 2 weeks of using it regularly in order to get the optimal effects of it. especially when you do have asthma. And if you're depending, again, it's all dependent on the situation, but if you are avoiding it and then using the oral steroids, there's much more harm in that. So it's much better to be on a low dose of a preventer controller medication for a period of time than to be on this roller coaster ride of off oral steroid, off oral steroid. There's much more harm that can be caused by that.
That's great that you mentioned that. Someone here has just asked how they get referred to someone like you, Sue, to ensure that their child has a plan in place that will make sure that they're taking their medications properly. So what do you guys suggest? How do we get...
Is that one of my friends putting a
I
little
don't know. I don't
plug
have a
in
name
there?
here.
So I myself specifically, I'm at SickKids, but there's some amazing respiratory and asthma educators out there in different programs. I think for the majority of people, there is the primary care asthma program, which I know that the Lung Association, and we've started now with SickKids, we've started community partnerships as well. And so there's some really great clinics and there's some great respiratory educators out there. And I think some of them can be self-referred, I think, or if the family doctor or pediatrician I think that's probably the best, one of the best ways. I don't know if there's private clinics, but I know that's probably one of the best ways.
Okay. Yeah, so at the Lung Association, we do have the primary care asthma program. It's all across Ontario. It's really a program that ensures that patients with asthma do get time with an educator as well as a primary care physician who is going to be providing an asthma action plan and doing all of the necessary steps to keep patients supported properly. We also, at the Lung Association, have our lung health information line, and we have certified respiratory educators who are happy to answer any of your questions at any time. You can call us, you can email us, or we also have a live chat function that you can find on our website. And if you call us, we're happy to talk through that with you. We can also give you some techniques, and as Sue has mentioned, we do have videos on our website as well. So there's tons of resources on the Lung Association website that we can help support patients with asthma with, as well as just straight talking to one of our people. So thank you for that. What's this question? So I've been taught previously to have patients with exercise-induced bronchospasm use their Ventolin pre-exercise. More recently, I've read that we should only have patients use rescue meds at times of symptoms during exercise or for pre-extreme competitions. What are your guys' thoughts on that? What do you suggest?
So if you're using your Ventolin pre-exercise and it's fairly rarely, like, I don't know, once a week or something, then I think that's fine. But if you're using Ventolin on a daily basis, for symptoms, then I think or as a prophylaxis, then I do think it's probably worth revisiting. Because I think regular Ventolin use is probably not a good idea. Yeah.
I think the other thing too is to ensure the diagnosis is correct, because exercise-induced asthma is very different from sort of regular asthma in itself. It produces different inflammatory mediators, so we're actually treating something different. So I think it's important, I mean, like I had mentioned before, a lot of times when you get the underlying asthma under good control, the exercise symptoms will go away. Yeah. So I think that's important to ensure that the diagnosis is
if you have good asthma control, a lot of exercise-induced asthma goes away. And it would also be useful to confirm that what's actually happening during exercise is actually asthma. Presumably if the Ventolin or the pre-treatment is preventing any bronchospasm, then presumably that's what it is. But certainly people get short of breath with exercise for all sorts of reasons. Mm-hmm. Yeah.
Okay. The next question is just about prevention. Is it best to just give the blue puffer or use steroid puffers after an attack?
After an attack?
After an attack.
So after an attack, when you're recovering, you don't need to use your blue puffer. Your blue puffer is purely, in my mind, a rescue. So if you're having symptoms, you use it to feel better now. If you feel better now, you don't need to take it. The controller puffers you use as per your action plan. So whatever people have said, this is what you do to prevent things, that's what you do.
So the key there is to get an action plan that's specific to you so that you
think
know
so.
what to do and how to manage your situation if you start to get a little bit out of control. Great.
Yeah.
I do want to make a point here is that it's very important that you're not using your blue puffer on a daily basis. I think if that's the case, then you need to go get reassessed and make sure that you're on the appropriate controller medicine, because it's very dynamic. Asthma is very dynamic. We've been sort of talking about this, and it can change over time, and that's why the regular follow-up and with a medical professional is extremely important, because we don't have a magic formula to know that this exact controller medicine at this dosage is going to be, good for this type of specific patient. So I think that's where the feedback is very important. But you do not want to be using just your Ventolin on a regular basis, like every day. That's actually very dangerous.
One of the questions here is about asthma action plans and emergency visits. So I can answer part of this, but I'll let you guys start speaking about it. So when a patient is brought to the emergency department with an asthma attack, kind of what's the course of treatment, and then do they leave with an asthma action plan, or does that not happen from your experience?
So an asthma attack is managed a little bit differently because you get a whole bunch of different medications and people will escalate until you feel better. So it can involve inhaled Ventolin through it's usually not, sometimes it's through the aero chamber, but often it's with a mask and a nebulizer because you can deliver oxygen at the same time. And if that's not helping, children will often receive intravenous medications. And most emergency rooms will have a whole pyramid where they'll climb up and support the child. And in the very extreme situations, you may end up in the intensive care unit. You may need a breathing machine to help you breathe. So that's kind of very different from what we're talking about now. In terms of action plans, it probably varies from emerge to emerge, because I think the vast majority of emerges do a great job, but their focus is really on helping you right now, and let's get you better, and then okay, you're well enough, go home and go see your family doctor or your pediatrician. And so I'm not sure that emergency rooms would give you an action plan as per routine. I would be surprised actually if they would. I don't know.
I think really, if they do, they just sort of give you something temporarily, but the intention is really to see someone within, I would say, a week. Really, I think that's probably the safest, is to go see your actual primary care provider for asthma within a week of that, so that they're alerted, and then they can do a quick assessment, at least do any adjustments from there on, and I think that's the most important thing.
Yeah. So at the Lung Association, we also have a program geared towards the emergency departments that has resources to help support management of an asthma episode in the emerge, but also exactly like you said, Sue, once a patient is discharged, what are the next steps that's important for them to do, which is seeing their primary care physician and determining how to best manage this so that there isn't another attack that comes. So that's great.
Can I just jump
Absolutely.
in that often too, because we were in the emerge once a month? I don't even know. I feel like it was once a month we were in emerge. And that's not an exaggeration. I think we counted 20 times for Brody.
Wow.
And he was 3. He wasn't 3 yet. And so one of the things I found as a parent is through the respiratory clinic, we had an action plan. But then when you show up in emerge, they're treating the moment, right? They're treating that moment to get him under control. And so a big part of, I felt, my role as a parent is to say, look, this is our action plan. They want to give him this Dex oral steroid in the moment. And part of I felt my role was saying, well, our action plan too is we would like to be able to give him prednisone over a series of days. And so having that conversation with the doctor and letting them know that there are other things that you've been working on with other doctors, and helping kind of bring them in the loop. Because often that emerge doctor is working with what they see in the moment, and they won't know about your action plan, and they won't know so much about, and that does sometimes inform their decisions about how they want to proceed. Because one time I questioned the doctor, I said, do we want to go with Dex or could we try prednisone first? And they actually did want to go with the prednisone. But they wouldn't have known that otherwise.
Yeah.
I mean, right? They wouldn't have known that was our plan.
Yeah, encouraging people to bring their plans with them so that you know has already been outlined, because like you said, everyone's unique. So to have that as a visual as well is good for the emergency department physician or healthcare team to see as well. Great. We are at time, so I just wanted to thank our panelists here for sharing your time with us today and your stories and your expertise. We truly appreciate it. Thank you to everyone who tuned in today and provided us with so many amazing questions. We really appreciate that. We will, for any questions that didn't get addressed, or even for the questions that we did talk about, we will be putting together a frequently asked questions resource that we will have on our website at the Lung Association that you can get access to. The video for this as well, and this came through as a question, will be available later on as well. So please come to our website and check that out. Again, I want to encourage everyone, this does not have to be the end of the discussion. If you have any questions about asthma, please feel free to call our lung health information line. Come to our website and come on the chat function, or please email us with your questions. We have certified respiratory educators who are happy to help you. Thank you again to all of you one more time, and thank you everybody again, and I hope everyone has a fantastic afternoon.